Everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting, important and a common topic, the stroke. The stroke or the cerebrovascular accident or the brain attack. All the indispensable concepts of stroke we are going to discuss today. Here we go. Stroke. Stroke is a sudden onset of a neurological deficit from vascular mechanism. So stroke is a sudden onset of neurological deficit from vascular mechanism. Stroke basically are two types. One, the ischemic stroke, which forms the majority of stroke patients, that is 85%. Ischemic stroke, as the name suggests, the blood flow to the brain is insufficient. Second category is hemorrhagic stroke, which forms about 15% of all stroke patients. It is because of the rupture of the vessel. So stroke is a sudden onset of neurological deficit because of vascular mechanism. Stroke basically are two types. One, ischemic stroke, where there is a decreased blood supply to the brain, which forms 85%, and hemorrhagic stroke, which is because of the rupture of vessel, which forms about 15%. Right. When a person with stroke comes, how are we going to localize the lesion? It could be in the cerebral cortex, it could be in the midbrain, pons, medulla oblongata, or cerebellum. How are we going to localize the stroke lesion? To understand this, we need to understand the circle of Willis. Circle of Willis is an anastomosis between two arterial territories. One, the internal carotid artery. Second, the vertebrobasilar territory. Strokes, because of the vertebrobasilar territory, we call it as a posterior circulation stroke. Stroke, because of the carotid arterial circulation, we call it as an anterior circulation stroke. So the two vertebral arteries come and pass through the medulla oblongata. So medulla oblongata is supplied by the vertebral artery in the lateral part, and the anterior spinal artery of the vertebral arteries supplying the medial part of the medulla oblongata. So medial part of the medulla oblongata is supplied by the anterior spinal artery. The lateral part of the medulla oblongata is supplied by the vertebral artery. The two vertebral arteries unite to form the basilar artery. So pons is supplied by the basilar artery. They divide into two posterior cerebral arteries in the midbrain. So midbrain and the thalamus is supplied by the posterior cerebral artery. It winds around, and therefore some part of the temporal lobe and primarily the occipital lobe is supplied by the posterior cerebral artery. This is about the posterior circulation stroke. The internal carotid artery gives rise to middle cerebral artery, which supplies almost the entire cortex, except the small anterior part, which is supplied by the anterior cerebral artery, which is united by the anterior communicating artery. So if we understand this basic blood supply of the different brain regions, then we can localize the stroke lesion. So the cerebral hemispheres, the lateral part is supplied by the middle cerebral artery. The cerebral hemispheres, the medial part is supplied by the anterior cerebral artery. The cerebral hemispheres, the posterior part is supplied by the posterior cerebral artery. So the cerebral hemispheres, the lateral part is supplied with the middle cerebral artery. So what are all the manifestations if the middle cerebral artery gets affected? So the entire cortex is supplied by the middle cerebral artery, except a small posterior part which is supplied by the posterior cerebral artery, that is the occipital lobe, and a small part the anterior part of the brain, which is supplied by the anterior cerebral artery, that is the medial part of the frontal lobe. So the entire cortex is supplied by the middle cerebral artery. So if the middle cerebral artery gets affected, person will have hemiparesis, one-sided weakness. Because the frontal cortex gets affected, person will have hemiparesis. Person will have hemisensory deficit. The opposite side gets affected, sensory loss because of the parietal lobe. The manifestations are always on the opposite side because the corticospinal tract crosses over to the opposite side and the sensory tracts also cross over to the opposite side. So if left side cortex gets affected, the manifestations are on the right side. So we have hemiparesis, hemisensory deficit, aphasia. The middle cerebral artery divides into the superior division and the inferior division. Superior division supplies the Broca's area and the inferior division supplies the Vernix area. The speech centers are situated for most of the right-handers are on the left side. So we call that cortex as dominant cortex where the speech centers are situated. So more than 90 to 95% of the right-handers, the dominant cortex is left, implying that the speech centers are on the left side. So the middle cerebral artery divides into superior division and the inferior division. Superior division supplies the Broca's area. So if the superior division of the middle cerebral artery gets affected, person will have Broca's aphasia. That means fluency is affected. He can understand, but if he can't talk. Non-fluent but sensible aphasia. If the inferior division of the middle cerebral artery gets affected, Vernix area gets affected, person will have Vernix aphasia. Comprehension is affected. He cannot understand, but he keeps on talking, nonsense talk. And Vernix aphasic patients, since the temporal lobe is affected, they usually do not have hemiplegia because the corticospinal tract does not traverse the Vernix area. So here is the person who talks nonsense and he does not have motor deficit. So bystanders will think that the Vernix aphasic patients are suffering from psychiatric disorder and usually they land up in psychiatric hospitals. Broca's aphasia, they can understand but they can't speak out and they will have hemiplegia because the corticospinal tract traverses the Broca's area, so they will have hemiplegia and they can have homonymous hemianopia also. So they can have aphasia, Broca's aphasia. If superior division of the middle cerebral artery gets affected, Vernix aphasia, if the inferior division of the middle cerebral artery gets affected. If the non-dominant cortex gets affected, they will have neglect, hemi-neglect on the left side. The dominant cortex, the speech centers are situated, the non-dominant cortex is responsible for the spatial orientation. The non-dominant cortex controls both the right and the left extrapersonal space, whereas the left dominant cortex controls only the right extrapersonal space. So if the left cortex gets affected, the right extrapersonal space is affected, but the right side can compensate for the right and the left, and therefore left cortex lesion does not produce right hemi-neglect. But if the right cortex gets affected, both the right and the left extrapersonal space is affected. The right extrapersonal space is compensated by the intact left cortex. There is no compensation of the left side. So right-sided cortical lesions produces left hemi-neglect. We can test it at the bedside by asking him to draw the 12 numbers of a clock. They put all the 12 numbers on the right side and they do not go to the left side, implying they have left hemi-neglect. So hemi-neglect is seen on the non-dominant or right-sided lesions. They can have apraxia. Apraxia is inability to perform a learned motor act despite motor, sensory, coordination and comprehension being normal. So they cannot perform a learned motor act. They may do it in bits and pieces, but they cannot do it in a continuous manner and in a logical manner, which we call it as apraxia. Apraxia is seen in left-sided lesions. It could be ideational apraxia, idiomotor apraxia or limb kinetic apraxia. Then they have homonymous hemianopia because the optic tract, the visual radiations pass through the lobes. They can have homonymous hemianopia on the opposite side. And then they have gaze preference. For a person to look to the right side, the fast movement, saccadic movement, the stimulus originates from the frontal eye fields area number 8 on the left side. So the saccadic path originates from the frontal eye fields area number 8 on the left side, crosses over and goes to the PPRF on the right side, which is in the pons, the para-median pontine reticular formation. which controls the right lateral rectus and the left medial rectus through medial longitudinal fasciculus. So when the left frontal cortex is stimulated, the eyes will move towards the right side because the right PPRF is stimulated. It stimulates the right lateral rectus and left medial rectus to the MLF. So when the left frontal cortex is stimulated, eyes will move towards the right side. If the left frontal cortex gets affected, eyes cannot move to the right side. So eyes will be looking to the same side of the lesion. So they can have gaze deficits or preferential gaze to one side. So these are all the manifestations if the middle cerebral artery, that is the lateral part of the cerebral hemisphere, if it gets affected. The cerebral hemisphere, the medial aspect is supplied by the anterior cerebral artery. The medial part of the frontal lobe where you have the leg areas and the bladder area. So leg area is involved. So they'll have predominantly hemiparesis, but leg area affected more than the hand area. They can have hemisensory loss, again leg area being affected more than the hand, and they have urinary problems because the bladder center is in the medial part of the frontal lobe. So these are all the manifestations of the anterior cerebral artery. So they can have paralysis and sensory loss of the leg more than the arm. They can have urinary incontinence, they can have gait apraxia, and they can have the re-emergence of the primitive reflexes, that is sucking reflex and grasp reflex. The primitive reflexes are the reflexes which are present in infancy, but the moment the brain starts getting mature, these reflexes disappear. So the persistence of these reflexes or disappearance and the re-emergence of these reflexes indicates that that particular lobe is affected or damaged or there's a lesion. So there is a re-emergence of the primitive reflexes. This is about the anterior cerebral artery. If the posterior cerebral artery gets affected, the posterior part of the cerebral hemisphere gets affected. So they can have cortical blindness. The occipital cortex is, its function is for vision, and therefore when the occipital cortex gets affected, they'll have cortical blindness. Because the temporal lobe is also supplied by the posterior cerebral artery, they can have memory deficits, they can have homonymous hemianopia, and since thalamus is also supplied by the posterior cerebral artery, they can have sensory loss and painful sensations or dysesthesia. This is about the cerebral hemisphere supplied by the posterior cerebral artery, the posterior aspect. Then we have the brainstem midbrain. Midbrain is predominantly supplied by the posterior cerebral artery. So the third and fourth nerves are there in midbrain. So they have ipsilateral third nerve palsy with contralateral hemiplegia, and the midbrain is the center for all vertical eye movements. Pons is the center for horizontal eye movements. So if midbrain gets affected, they can have paralysis of vertical eye movements. If pons is affected, they'll have paralysis of horizontal eye movement because the PPRF, paramedian pontine reticular formation, gets affected. So midbrain lesion, that is the posterior cerebral artery lesions, they'll have ipsilateral third nerve palsy with contralateral hemiplegia and paralysis or paralysis of the vertical gaze. Brainstem pons. Pons is supplied by the basilar artery. So if basilar artery gets affected, pons gets affected, they'll have facial paralysis. Because third and fourth are in the midbrain, 5, 6, 7, 8 are in the pons. So seventh nerve gets affected, they'll have facial paralysis. The PPRF gets affected, so all the horizontal eye movements gets affected. Then they can have pinpoint pupil because there is a pons is supplied by the single basilar artery. So if there's a hemorrhage, the blood goes diffusely to both sides of the pons, and both sides the sympathetic tracts gets affected. Both sides it's like a Horner syndrome, so they'll have meiosis or pinpoint pupil. The medulla oblongata. The medial part of the medulla oblongata is supplied by the anterior spinal artery. The lateral part is supplied by the pica, posterior inferior cerebellar artery. If the medial part of the medulla oblongata gets affected because of the anterior spinal artery, three structures gets affected. The 12th nerve, the posterior column, and the corticospinal tract, resulting in hemiplegia, posterior column lesion manifestations, and the 12th nerve involvement. But if the lateral part gets affected, they can have severe vertigo, they can have Horner syndrome, they can have ataxia, the lateral part of the medulla oblongata. Hemiparesis is not a feature of the lateral medullary involvement, that is the Wallenberg syndrome, because the corticospinal tract is in the medial part of the medulla oblongata. Cerebellum. Cerebellum is supplied by pica, posterior inferior cerebellar artery, Ica, anterior inferior cerebellar artery of the basilar artery, and SCA, superior cerebellar artery of the basilar artery. So if these arteries gets affected, the cerebellum gets affected, they'll have ataxia, they'll have incoordination. If ICA, anterior inferior cerebellar artery gets affected, the labyrinthine artery gets affected, so they can have deafness too. So this is how we localize. This is very, very important, the stroke localization by vascular territories. Next, not all persons who present with weakness need to be suffering from cerebrovascular accident. There are lots of stroke mimics. One of the common and strong stroke mimics is hypoglycemia. So whenever a person comes with weakness, always try to rule out hypoglycemia by checking out the blood sugar level. So what are the other stroke mimics which mimics exactly like stroke, but it is not because of the cerebrovascular territory involvement? First and foremost is metabolic, that is hypoglycemia. Second is seizures, what we call is Stotts palsy. After seizures, they can have a deficiency of nutrients and the weakness may persist. So we call that as Stotts palsy or Stotts paralysis. Post seizure, a brain tumor or bleed into the tumor can present with weakness, and a complicated migraine also can present with weakness. So these are all the stroke mimics. Investigation, as I said, one of the common mimics of strokes is hypoglycemia. So we have to check on the blood sugar level. We have to do the hypercoagulable profile because they have a tendency to cause clot. Then we have to do cardiac evaluation, ECG and echo. And then finally we have to do CT scan and MRI. The CT will be a non-contrast CT scan because we should not get confused with the hemorrhage. Right. So now that we know all the localization, what are the primary and secondary prevention of stroke? That is the risk factors. What are the risk factors involved in stroke? Obviously, the atherosclerotic risk factors are very important risk factors in causing stroke. So what are the conditions which can give rise to atherosclerosis? Hypertension, diabetes, hyperlipidemia, family history of stroke or past history of TIA, smoking and alcohol. These are the risk factors for atherosclerosis. For cardioembolic risk factors, very important is atrial fibrillation, myocardial infarction, valvular disease and infective endocarditis and dilated cardiomyopathy. Right. So how can we prevent the stroke? We can give antiplatelet agents which reduces the new stroke by as much as 25 to 30%. We can give aspirin about 50 to 325 milligram. It inhibits thromboxane A2 and the platelet aggregating and constricting prostaglandins. We can give clopidogrel which blocks ADP receptor, adenosine diphosphate receptor. We can give dipyridamole which inhibits the platelet uptake of adenosine. Generally, we give dual antiplatelets for about 3 weeks to 3 months, that is 21 days to 90 months. Then we switch over to single antiplatelet agents. For cardioembolic strokes, there is no endothelial injury. It is because of the decreased blood flow. So there is no role for platelets. We call this as red thrombus. Since there is no role for platelets, there is no use of giving antiplatelet agent. So we give only anticoagulants. So we give anticoagulants for embolic strokes. Because of red thrombus and there is no role for platelets, we give anticoagulants. So very important, we give antiplatelets for white thrombus, that is arterial or endothelial injury. For venous stroke and cardioembolic strokes, we give anticoagulant because there is no endothelial injury, there is no role for platelets. And we can do carotid revascularization if it is severe symptomatic, more than 70%. If we do carotid revascularization, there is a relative risk reduction to as much as 65%. The stroke, as I said, ischemic stroke is about 85% and hemorrhagic stroke is about 15%. The ischemic stroke in 85%, 17% is because of atrial fibrillation, so we can consider warfarin. And carotid strokes is about 4%, we can consider carotid endarterectomy or stenting, and others are 64%, we give a symptomatic treatment. When we come to hemorrhagic stroke, which is 15%, subarachnoid hemorrhage forms about 4%, we can either clip or coil the patient, and hypertensive intracerebral hemorrhage is about 7%. We can consider antihypertensive agents, or if it is cerebellar hemorrhage, we can do a neurosurgical intervention, and others it depends upon the symptomatic treatment. Pathophysiology, ischemic stroke. Ischemic stroke can be either the small vessel disease because of the lacunar infarction, very small vessels are involved, usually because of hypertension, and the four important lacunar strokes are pure motor hemiparesis because of the internal capsule involvement or pons, or pure sensory stroke when the thalamus is involved, or dysarthria clumsy hand syndrome or ataxic hemiparesis where we can have dysarthria or ataxia in the pontine lesion because the bulk of the cerebellar afferents pass through the pons, and therefore if the pons gets affected there can be cerebellar manifestations, and therefore the pontine lesions we can also get cerebellar manifestations like dysarthria clumsy hand syndrome or ataxia. In ataxic hemiparesis, the ataxia. So these are all the four important small vessel or lacunar strokes. The large vessel strokes, or because of the decreased because of decreased blood pressure hypotension, we have border zone infarcts. The proximal parts of the ACA and NCA, there's a good blood flow, but because of the hypotension, as they go distally, the blood pressure becomes decreased, and therefore there's an infarct between the ACA and NCA at the distal parts, or NCA and PCA at the distal parts. The proximal parts get good blood supply because there's no block, it's only a decreased blood flow. If there's a border zone infarct between ACA and NCA, or there could be a block between the NCA and PCA, posterior water zone infarct, what we call as balance syndrome. If there's a border zone infarct between the ACA and NCA, the hip muscles and the shoulder muscles get affected. We call that as a man in barrel syndrome. The transient ischemic attack, the ischemic disease or the deficit resolves within 24 hours, usually within 1 hour, even without any radiological evidence. We call that as a transient ischemic attack. And one of the classic features of the transient ischemic attack is amaurosis fugax. When there's a block in the carotid artery and the retinal artery, the vision is lost in a shaded manner coming from the top to the bottom. We call it as amaurosis fugax. It's a warning sign of the carotid stroke. The stroke recovery modifying factors. So what all can we do to modify the propagation of the stroke? One of the important factors for stroke modification is collaterals. If there's a good collaterals between the ACA, MCA or MCA, PCA, or between ICA and ECA, the stroke is limited. So one of the important stroke modifying or ischemia modifying factors is collaterals, the other being blood pressure, the specific site, and the mechanism of vessel obstruction. These are all the ischemic modifying factors, but the most important will be the development of collaterals. The pathophysiology for hemorrhage. Hemorrhage, usually the consequences of hemorrhage is because of the raised intracranial pressure. Because the blood starts leaking, it starts filling up the brain. So brain has got no place to get displaced because an overlying skull limits its expansion. So the pressure in the brain rises, the intracranial pressure. So hemorrhagic strokes, basically we are concerned about the raised intracranial pressure. So they can have headache, vomiting, and one of the important factors for raised intracranial pressure is decrease in consciousness, that is drowsiness. So hypertensive hemorrhage, if there's a bleed because of hypertension, 4 characteristic sites are involved: putamen, pons, thalamus and cerebellum. If putamen gets affected, there will be contralateral hemiplegia with homonymous hemianopia. If the thalamus gets affected, the eyes go downwards because thalamic hemorrhage goes and impinges the top of the midbrain where we have the vertical gaze center. The up gaze fibers cross, but the down gaze fibers do not cross. So if they impinge on the top of the midbrain, the crossing up gaze fibers get affected, so they cannot look upwards, they'll be looking downwards. The hypothalamic sympathetic fibers originate near the thalamus, so since they get affected, the sympathetic pathway gets affected, so they cannot dilate it, they'll be small. So thalamic hemorrhage, small pupils, myotic pupils and eyes will be looking downwards. And they can have sensory deficits because the sensory tracts pass through the thalamus. Pons, they have pinpoint pupils because once there is a basilar artery rupture, the blood diffuses to both sides of the pons. So both the sympathetic tracts gets affected. So dilatation gets affected on both sides. So both sides of pupils will be small, pinpoint pupils. They can have seventh nerve involvement. The PPRF gets affected, so they'll have impairment of horizontal eye movements. They can have quadriplegia. If cerebellum gets affected, they'll have headache, vomiting and gait apraxia. What is the etiology of stroke? When we consider the ischemic stroke, it could be either the thrombosis, embolism, or uncommon causes. The thrombosis, the Lachner stroke, small vessels, or the large vessel thrombosis, or it could be because of hypotension. The small vessel or the large vessel or the hypotension. When we take the embolic occlusion, it could be the artery to artery, like from the internal carotid artery or from the aortic arch or from the other arteries, or it could be arterial dissection. It could be from cardioembolic, it could be atrial fibrillation, myocardial infarction, dilated cardiomyopathy, or bacterial endocarditis. The other uncommon causes of ischemic stroke, are hypercoagulable disorders like protein C, protein S deficiency, antithrombin 3 deficiency, and antiphospholipid antibody syndrome. It could be venous sinus thrombosis or fibromuscular dysplasia or vasculitis. It could be systemic or primary or secondary to meningitis. So these are all the important causes of ischemic stroke. What are all the important causes of hemorrhagic stroke? First and foremost will be hypertension. Hypertensive hemorrhage is one of the most common cause of hemorrhage. If there is a hypertensive bleed, the sites could be in the pons, putamen, thalamus, cerebellum. The hemorrhage or blood in the brain could be because of head injury, where the intraparenchymal hemorrhage, it will be in the frontal lobe or in the anterior temporal lobes, or it could be subarachnoid hemorrhage or subdural hematoma or extradural hematoma. Transformation of prior ischemic stroke, if it is a large infarct, there could be a transformation of the ischemic stroke into a hemorrhagic stroke. A metastatic brain tumor may be responsible for hemorrhagic stroke. Coagulopathy, a deficiency of procoagulant factors, can give rise to hemorrhage. But generally it does not present suddenly, it takes some time to develop. So if we see hemorrhagic stroke developing over a few minutes to hours, then we have to think of a coagulopathy, because deficiency of coagulation factors will take a certain time to develop. And on imaging, you can find a meniscus sign where the plasma nicely settles down. It could be coagulopathy, it could be drugs like cocaine or amphetamine, or arteriovenous malformation where there is a lobar hemorrhage, or aneurysm, rupture of the aneurysm, where it could be subarachnoid hemorrhage. Amyloid angiopathy, usually seen in elderly people, senile people, a deposition of amyloid in the vessels causing rise to amyloid angiopathy and hemorrhage, where we find hemorrhage in the lobes, or other conditions like cavernous angioma or dual arteriovenous malformation or capillary telangiectasis, where we commonly see in brainstem. So having understood these basic pathophysiological causes of stroke and causes of stroke, now let's focus on the treatment, the acute treatment of ischemic stroke and the acute treatment of hemorrhagic stroke. The acute treatment of ischemic stroke, first we have to give a good medical support. We have to lower blood pressure gradually. If we unknowingly reduce the blood pressure in a very quick manner, the blood pressure falls down and there could be ischemia. So we may be doing more harm than good. And therefore we have to reduce the blood pressure gradually and slowly, because we may exacerbate the ischemic condition if we reduce the blood pressure very fast. We reduce the blood pressure very fast only if the BP is more than 220 by 180, or when we are planning thrombolysis where we reduce the BP to a level of 185 to 110. We want it below that level. Intravenous thrombolysis, very, very important in treatment of acute ischemic stroke. The ischemic deficits of less than 3 hours duration, but some countries go to the window period of even 4.5 hours. So if the ischemic stroke presents within 3 hours, or sometimes some countries take the window period up to 4.5 hours with no hemorrhage by CT scan. We take a CT scan, and if there is no hemorrhage by CT scan, patients may benefit from thrombolytic therapy with intravenous recombinant tissue plasminogen activator. So thrombolytic therapy, very useful for ischemic stroke if we rule out hemorrhagic stroke by CT scan, and if we initiate therapy within 3 hours, but some countries the time window is extended to 4.5 hours. Endovascular revascularization, if there is a thrombus or an embolus into the large vessel, the CT angiography, if we do it and confirm it by CT angiography, the ischemic stroke from the large vessel intracranial occlusion may benefit from embolectomy, mechanical embolectomy within 6 hours duration. Some countries they take up to 7.5 hours, but we usually say 6 hours duration. The antiplatelet agents, 325 milligrams per day, we can give aspirin. Anticoagulations, heparin and oral anticoagulation. Is there any role for acute ischemic stroke? The trials and studies have not shown any beneficial role of heparin or anticoagulants. There is no convincing data of trials for the benefit of heparin or anticoagulants in an acute management of ischemic stroke. Then we can give neuroprotection. Hypothermia, when there is a decreased temperature, brain is able to withstand the hypoxemic conditions better when the temperature is on the lower side. Hypothermia is one of the important neuroprotective factors. So hypothermia is effective in coma following cardiac arrest. So this is the treatment of acute ischemic stroke. What is the treatment for acute hemorrhagic stroke? Non-contrast head CT scan we take to confirm hemorrhage. Rapidly identify and correct any coagulopathy. Person may be taking anticoagulants. So we have to see and correct the coagulopathy, or some disorders may affect the coagulation cascade pathway, and therefore we have to identify and treat the coagulopathy. Control systolic BP at least below 180 millimeters of mercury. Control of hypertension is very essential, but it has to be gradual and up to 180 millimeters of mercury. Presumption for if a person is in a stuporous or a comatose condition, as I said, hemorrhages causes a blood accumulation in the brain. Brain cannot expand further because of the overlying skull, and therefore there is a raised intracranial pressure. So if there is a presumptive suggestion of raised intracranial pressure in the form of a stuporous condition or a comatose patient suffering from a hemorrhagic stroke, we initiate treatment for raised intracranial pressure. We can give osmotic agents, especially mannitol for edema and mass effect. Glucocorticoids have got no role. They are not helpful in reducing edema or raised intracranial pressure of stroke patients. We give mannitol as an osmotic diuretic. The neurosurgical intervention. Is there any role for neurosurgery in hemorrhagic stroke? Yes, there is a definitive role for neurosurgeons. Cerebellar hematoma, neurosurgeons have got a definitive role in cerebellar hemorrhage. But according to other trials and other studies, there is no role for neurosurgeons in other hemorrhagic conditions other than cerebellar hemorrhage. So other conditions, data don't support the surgical intervention other than cerebellar hemorrhage. Prognosis is determined by the volume. If there's a lot of blood volume, the prognosis is going to be bad. And again, it depends upon the location of the hematoma. If it is in the pons or brainstem area, the prognosis is going to be bad. The prognosis is 40% of patients with hemorrhagic strokes die. So there's going to be a bad prognosis. So these are all the important, essential, indispensable concepts of stroke one has to know. I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post on to my YouTube channel. But please like and subscribe my channel, my educational YouTube channel, Dr.Sreenivas Medical Concepts, and my FB page, Dr.Sreenivas Concepts. Thank you. Bye.